Hello, I'm Julie Gayle. I'm going to be discussing the Women's Health Physical Exam. Regardless of the setting you currently work in or plan to work in, you will encounter women and women at various stages within their lives. A collaboration between AAFP, American College of Obstetricians and Gynecologists, or ACOG, which you'll hear me refer to, NPWH, which is the National Association of Nurse Practitioners in Women's Health, and the American College of Physicians. From this collaboration came the Women Preventative Services Initiative, or WPSI. And this initiative recommended that women receive at least one preventative care visit per year, beginning in their adolescence and continuing across the lifespan to ensure the provision of all recommended preventative services. The primary purpose of the Well Woman visits is the delivery and coordination of recommended preventative services as determined by their age and risk factors. These services may be completed at a single visit as part of a series of visits that take place over time to obtain all necessary services depending on the woman's age, her health status, reproductive health needs, pregnancy status, and risk factors. As a healthcare provider, it's important to be aware of the recommended screening for cancer and other chronic conditions that require intervention, such as yearly clinical breast exams and mammography beginning at age 40. Rather than attempt to keep abreast of the various organizations that make these recommendations, for instance, the ASCCP, which makes recommendations for cervical cancer screening and management, the Women's Preventative Services Initiative provides evidence-based recommendations for the well woman in an easy-to-read chart that's accessible via the link provided here. Primary care for women should include healthcare screening, as already mentioned, based on their age, risk factors, and even your examination findings. You will find a list of the recommended services for the different age groups for women in the last 3 slides of this presentation. These recommendations are evidence-based with a rating of A or B by the U.S. Preventative Services Task Force. The chart also provides recommended immunizations from the CDC's Advisory Committee on Immunization Practices. So like any exam, the women's health exam consists of the collection of subjective data from the history and the collection of any objective data that you may gain from the physical exam. Women may seek care for various reasons. They could present with specific complaints or problems, which would lead you to conduct a focused or problem-focused exam, or they may just present for an annual checkup or an annual exam, which then you would initiate a comprehensive or complete exam. Like other exams, the women's health exam consists of a chief complaint or a reason for visit, and if there is a presenting problem or issue, then of course a history of a present illness or HPI is also included. Inquire about allergies and current medications. Reviewing the current daily medication often clues you into their current and past medical history, so I typically go from discussing their medications to the past medical history, and then any past surgery, any history of illnesses, injuries, hospitalizations, or emergency or urgent care visits. It's important to assess for any family history of any cancers or chronic conditions. The assessment of a family history of any breast, ovarian, or other malignancies is important in determining the risk for the woman and the need to offer any screening possibly earlier than those without risk factors. It's also important to note that the inclusion of pertinent family history of specific conditions is important to address if you're working up a problem specific to the condition. For example, if you're working up a patient with a breast lump, then even if they don't have a family history of breast cancer, you would want to include the pertinent negative, or if they do have a history, because that's relating to the problem you're working up. Psychosocial history This is a good time to assess for any substance use or misuse or any interpersonal or domestic violence. Exercise and nutrition should be assessed and counseling provided during all preventative exams. A comprehensive and problem-focused exam should always include a review of systems. The level of visit, whether you're conducting a high-level visit like a level 4 or a low-level visit, will dictate how many systems that you must address and document in your review of systems. This slide contains components of the health history that are pertinent to women. So first, your menstrual history. You want to inquire about their last menstrual period. Are they having regular cycles? When was their last normal cycle? Are they having any bad cramping, heavy bleeding, any bleeding in between periods? And age of menarche, when they begin menstruation. If the complaint is specific to menstrual bleeding, you would of course include your menstrual history in your HPI, because it'd be a problem you were possibly working at. GYN history, this can be combined with sexual history or even your cancer screening. So in your GYN history, you want to inquire about any previous gynecological problems or issues, any previous gynecologic surgery. When was your last Pap smear, if you wanted to combine the cancer screening. Last mammogram, any history of any sexually transmitted infections, and any history of screening for them. They may say no, they don't have any history, but they may have not ever been screened. Obstetrical history, how many pregnancies. You can use the GTPAL, where it's gravida, how many times they've been pregnant. Term, how many term babies, which would be 37 weeks and above. Preterm would be less than 36 weeks. Abortion would be less than 20 weeks gestation. A pregnancy loss less than 20 weeks. And then living, how many living children does the patient have? So you could include a section on contraceptive history, and you can even combine any just hormone replacement therapy in that, because sometimes if you're thinking of prescribing contraceptives or any kind of hormones, it's important to inquire, have they used any in the past, and did they have any side effects or any problems? But also just determining, when you're asking questions about the menstrual history, contraceptive history, is this patient, if they're of childbearing age, are they trying to get pregnant, or do they need to be on anything to prevent pregnancy? Sexual history, you want to inquire about, are they having sex with men, women, both? What type of sex? Again, you can include your history of STDs here, or in your GYN history. And then are they using implementing safe sex practices? And then, of course, your cancer screening, your mammogram, Pap smear, and then are they up to date on their vaccinations? So after you've collected a very thorough history, you are going to move on to the physical exam. You'll make sure they've emptied their bladder, give them a gown, typically have them open up to the front because I will do a breast exam, and then have a sheet where they can drape it over their lap. And of course, this is if you're doing the head to toe GYN exam too. So your physical exam will include constitutional, which is like vital signs, general appearance, neck, so palpate the thyroid, listening to heart and lungs, listening to abdomen, palpating abdomen, of course, any lymph nodes. Skin assessment, this is a good time to look for any skin lesions that could be suspicious for malignancy. Neuro, psychiatric is usually orientation, mood, affect, and then your GYN exam. After palpating the thyroid, listening to heart and lungs, you can move on to the breast exam. It's not typically recommended to wear gloves for the breast exam unless they have any open wounds or anything. You can use any of the different palpation techniques of the breast exam. You can see listed here: wedge, vertical strip, circular. I mean, it's essentially just making sure you cover all the breast tissue, and that does include breast and the axillary region, because there is breast tissue up there. You want to alternate between light and a little bit deeper palpation, noticing if there's any tenderness, lumps, bumps, or when we say something about symmetry, it's not uncommon for one breast to be larger than the other in women, so it's important to inquire, has this always been this way? Same with nipples, because nipples can be inverted and everted. So if they've always had that, or again, if this is something new. During the breast exam, this is a good time to encourage the patient to be checking their breast routinely, and preferably after their cycle when their breasts are less tender and bumpy, and you just encourage them to be aware of their breast so that if there's any changes that they will come and get it looked at by a healthcare provider. And again, you want to only expose the areas that you're assessing. And I typically will, if they do have a breast complaint, I typically begin with the normal breasts before I palpate the abnormal. So you want to save the most invasive part of the exam at the end, which would be your pelvic exam. Be sure that there's a chaperone present. I would say anytime the patient is unclothed, you'd want to have a chaperone present. Assure that they've emptied their bladder before the exam. That can make it uncomfortable, and it can make it difficult for you trying to find the cervix. Assure their privacy. Make sure that you come in there with all the equipment you need so that you're not going in and out of the room while they're disrobed, or particularly once they're up in stirrups, no one should be coming in and out of the room. And if you can do a privacy curtain, which is kind of goes over the door in case the door does open or someone does, then that could protect the patient a little bit more. Equipment for the pelvic exam includes, of course, an exam table equipped with stirrups. You want to make sure that the table and the patient is positioned correctly and the stirrups fit the patient. So you may have to move them in towards the bed for your shorter patients. Make sure there's a flexible light source. The vaginal speculum, which we'll talk about, does come in different sizes. You want to make sure you use the appropriate size. Make sure you wear gloves for the pelvic exam. The vagina is not sterile, so you don't really need sterile gloves, but you want to be careful when you are doing the exam that you're not touching them or touching dirty, then touching the lights or touching anything else. So just be aware of that. You want to have some kind of, whether it's warm water or lubricating jelly for lubrication of the speculum. And then, of course, have your equipment for whatever test you're going to be doing, whether it's Pap Smear, collection of cultures for chlamydia, gonorrhea, wet mount, or hemoccult testing. Prior to the pelvic exam and during the pelvic exam, you want to be sure that you're communicating, explaining to the patient kind of what you're doing and what you're looking for. Encourage techniques to promote comfort and relaxation. Just telling them about what's about to happen. You may feel a little pressure, or you may hear some clicking if you're using like a plastic speculum, sometimes telling them ahead of time and preparing them. Avoid using terminology that's could be, interpreted a certain way. So like if you use a speculum, you're like, oh, we need a different size, or we need a bigger one. I mean, you just want to kind of watch what you say while you're down there doing the pelvic exam. Also to consider, well, first, this is also a great opportunity for teaching, like to tell them what you're looking for, what would be considered normal, what would be considered abnormal. You want to try to maintain eye contact with the patient as much as possible. Watch your verbal and nonverbal communication. Special considerations would be if you've got a patient who this is, an adolescent, they're real nervous, or it's their initial pelvic exam, you want to definitely make sure you take time with them. If it's a client with a mental or physical disability, a language barrier, like if they're hearing impaired, make sure you've got a translator in the room during the exam. Or if this is a sexual assault, patient, or they've had that in the past. These are things you want to know about and consider and be careful during the exam. The pelvic exam consists of the assessment of the external genitalia and the internal genitalia. To begin with the external genitalia, this will be assessed through inspection and palpation. An examination of the external female genitalia, these are some structures to be familiar with. The external genitalia or vulva consists of the mons, pubis, the labia majora, labia minora, clitoris, and the glandular structures that open into the vagina. The size, shape, and color of the structures may vary among individual women and racial groups. And typically normal hair distribution, if present, is in the shape of inverted triangle centered over the mons pubis. Inspection of the external genitalia will include assessment of skin pigmentation, hair distribution, the presence of any lesions, rashes, infestations, any discharge noted, any bulging, which should indicate pelvic floor dysfunction. You should have already donned gloves, but for this part, you're going to expose the clitoris, urethral orifice, and the vaginal opening by gently retracting the labia minora. You're going to inspect for any cysts or other lesions and inspect the area of the Bartholin glands, as normal Bartholin glands typically are not seen or felt. Then you're going to ask the patient, as you insert an index finger into the introitus, to perform the Valsalvan maneuver or bear down while you check for any cystocele, rectocele, or uterine prolapse. On inspection, if you notice any enlargement or redness surrounding the Bartholin or Skenes glands, you'll want to insert your index finger into the vagina and your thumb on the outside and palpate the tissue between your internal and external fingers. Check for any discharge from the ducts, and if any discharge is noted, obtain a culture. And this picture demonstrates palpation of the Bartholin and Skenes gland. And you may see it indicated on documentation as negative BSU, negative Bartholin, urethral, and Skenes gland. If you have a patient with an inflamed Bartholin gland, typically you'll see this on inspection of the external genitalia, like in this photo here. Once you've inspected and palpated the external genitalia, you're going to conduct an evaluation of the internal genitalia by way of the Speculum Exam and Bimanual or Pelvic Exam, and possibly the Rectovaginal Exam. This and the next slide have some diagrams of the internal female genitalia. In the physical exam of the internal female genitalia, you're going to be looking at the vagina, cervix, uterus, and adnexa, which adnexa includes the fallopian tubes and ovaries. During the speculum exam, you will make sure you lubricate the speculum with warm water or lubricating jelly. You want to make sure you have gloves on, secure the speculum. I typically secure the speculum in my right hand. I'm right-handed. Insert two fingers in the introitus and kind of push down and encourage them to relax those muscles, and then come behind my two fingers with the speculum at like a 45-degree angle, because you're not going to want to put the speculum in just straight, right? You want the smallest diameter to go in. And you're basically going to insert it at a 45-degree angle, pressing down until your speculum is all the way inserted. And then, of course, as you're going in, you're going to rotate it, and then, slowly open the blades of the speculum. And when you do that, then you will be kind of inspecting the vagina, the side walls of the vagina. Are they pink and rugated? Are they more pale and smooth, which you would suspect to see in like a postmenopausal woman? Any discharge, any lesions, any redness or inflammation. You'll also inspect the cervix. The color, position of the cervix, is it midline, is it pulled more to the right or the left? The appearance of the os is the opening of the cervix. Typically look like a little donut, I guess. And you want to note the surface of the os. Is there any lesions, any discharge coming from the cervix? And if there is it, mucopurulent? These would be things you would want to note on inspection. On inspection of the cervix, there are variations of normal findings. They may have a nulliparous cervix, where it just looks round or oval, the os does, and this would be in someone who's never had children before, or maybe has had children but their cervix never dilated. Maybe they had a C-section early. Parous cervix is going to be people who've had a few children, and it's more of that slit-like appearance. And then the last image here could be if they've had it like any cervical lacerations from difficult childbirth. During the speculum exam is when you'll obtain cultures for chlamydia, gonorrhea, wet mount specimen to evaluate for bacterial vaginosis, yeast vaginitis, or trichomonas, and then a Pap smear for cervical cancer screening. When performing a speculum exam, ideally your cervix will pop into view, like this picture here. However, that does not always happen, and sometimes it can be difficult locating the cervix. You can withdraw the speculum and reposition. Sometimes just looking, you'll see that the cervix is typically smoother than the side walls. So sometimes just identifying that difference in texture can kind of lead you to reposition and go towards that direction. Make sure their bladder's empty. Make sure they're all the way down to the edge of the table, as those things can impact whether you're able to view the cervix. And if you need to, you can take the speculum out, do the bimanual exam, figure out where the cervix is, and then do your speculum exam. Just a note that it is important that you do select the appropriate speculum. There are different kinds, like the most commonly kind are Peterson, which have more narrow blades, and then Graves have the wider blades, which is probably what's pictured here. They have metal speculums, plastic speculums. I know metal, typically you can use some warm water to lubricate the metal ones. Plastic, I already mentioned, I typically will warn the patient they may hear the clicking sound. And a lot of the plastics will have like a light source that you can plug into the bottom of it, which helps really with visualization for sure. And also to note your pediatric speculum or the small speculum, which even in the plastics they make small, medium, and large. Your small are going to be more commonly used on your adolescent patients or postmenopausal patients who aren't on any kind of hormone replacement. Other equipment needed to complete the Pap smear would be the brush. So there's a cyto brush, there's wooden spatulas, plastic brooms. You can see the different kinds. Most commonly used is the thin prep Pap with the cervical brush, or the cyto brush might be the most commonly that you'll see. So here you see that patients up in the lithotomy position and the stirrups. You want to make sure they're all the way to the bottom of, the end of the bed. Their legs are relaxed, and you can see this from the sagittal view that we have the speculum all the way inserted, like you shouldn't have any of the speculum hanging out. And then collection of the Pap smear here. Typically, I'll do collection of chlamydia, gonorrhea, any specimens for the wet mount prior to the Pap smear, just because sometimes that scratchy cyto brush can cause a little bit of bleeding. So I typically save that for last. And you can see she's going into the os, and you want to turn it clockwise about 5 times or so, just to make sure you get an adequate specimen. Speaking of adequate specimen for your Pap smear, just to review that the endocervix contains your columnar cells, where your ectocervix contains your squamous cells. So you want to get your broom in that area where the cells change from squamous to columnar, and that's also called the squamocolumnar junction. And that's also the transformation zone where most cervical cancers originate. This is just another image of the transformation zone. The red color around the os, this is from the vascular mucus producing endocervical columnar epithelium that's kind of grown or turned on itself, causing what they call cervical ectropion. A benign cervical finding of cervical ectropion or cervical ectoby. This is when the glandular cells that line the inside of the cervical canal are exposed. So you can see it kind of makes that red color around the os. This is typically most common when your hormone levels are changing and estrogen levels go up, such as in puberty, pregnancy, or taking birth control pills or hormones. This is a fairly common finding, and it's important to note that it's not cancerous or doesn't affect fertility. The last 2 images are Nabothian cysts, and these are relatively common. It's just where mucus becomes trapped and forms a cyst on the surface of the cervix. Abnormal findings may include a cervical polyp, which you could see, which the color is not that great because typically the polyp will be kind of a dark red or cherry red compared to the rest of the cervix. And then the middle picture would be mucopurulent discharge coming from the cervix, which would lead you to think there's some cervicitis, possibly caused from chlamydia or gonorrhea. And then the last photo is trichomonas, or it's the strawberry cervix, which is kind of like petechiae on the cervix, which is characteristic of trichomonas. And this is definitely what you don't want to see during your inspection of the cervix, because these are photos of carcinoma. Palpation of the internal female genitalia will be done through the bimanual or pelvic exam. This is done to evaluate the location, size, shape, position, and mobility of the pelvic organs. You're going to palpate the cervix, uterus, and adnexa, assess for any tenderness or masses, and assess the strength of the pelvic floor muscles. So after you complete your speculum exam, then you'll use lubrication and perform the bimanual exam. So you've already done the speculum exam, so you know where the cervix is. So you're going to go in with 2 fingers, go towards the cervix, and you want to kind of move the cervix around to assess for any cervical motion tenderness, which could be indicative of infection like chlamydia or gonorrhea. And then you're going to use your top hand to push the top of the uterus. You're basically pushing the uterus up towards your top hand because you want to get the uterus in between your internal and external hand. And you're going to want to assess the size of the uterus. Does the uterus move freely? Any masses, any tenderness? And then once you palpate the uterus or the cervix and the uterus, then you're going to sweep towards each side with you're sweeping with your top hand and trying to catch the ovary of each side in between your internal and external hand. Sometimes you can feel the ovaries, sometimes you can't, but you are assessing if there's any masses or any tenderness when you're doing that. You would not expect to palpate ovaries in a postmenopausal woman. During the bimanual exam, you'll also be assessing for the pelvic musculature to see if there's any prolapse or weakened muscles. And the next 2 to 3 slides kind of gives you an overview of the bones, joints, ligaments, and muscles in the pelvis. So the rectovaginal exam, this is reserved in cases where you need to confirm findings of a bimanual exam. Maybe you need to be able to palpate the posterior wall of the uterus, evaluate integrity of the rectovaginal septum, evaluate for any rectal masses. If you need to evaluate the integrity or tone of the rectal sphincter, presence of hemorrhoids, and if you needed to collect a hemocult, you would perform this. It's important to note in the rectovaginal exam that if you had any blood present in the vaginal vault or caused any bleeding with the Pap Smear, that you change gloves or double gloves because you would not want a false reading of your hemocult. So you want to make sure that you ask the patient or ask the patient about performing this the rectal exam. You don't want to surprise them necessarily, and you want to, sometimes if you have them bear down, make sure you use some lubrication. Makes it a little bit more comfortable for them. Pelvic floor dysfunction can be assessed by disassembling the speculum, using basically the base of the speculum inserted in, have the patient bear down, or maybe you could see a bulge regardless, but you would have a bulge anteriorly, which would be a cystocele. Posterior bulge would be indicative of a rectocele, which you can see these photos here. Typically, cystoceles, rectoceles, and you'll see uterine prolapse can have different severity, and it's usually on a grade system, grade 1 through 4. Here's an example of a uterine prolapse. For patients with prolapse that are causing symptoms or in need of surgery, and they may not be candidates for surgery, this is a slide that shows different pessaries. These are mechanical devices that provide support to the pelvic organs. Usually the practitioner has to size the patient or fit the patient for one. And of course they have to be able or be aware enough to remove it themselves, clean it themselves. In documenting your exam, make sure that you include the chief complaint or reason for visit, HPI, history, physical exam findings, any interventions, including patient education and counseling, referrals and consultations, and plans for follow-up. And the next few slides are examples of like documentation of your pelvic exam findings. And this slide is putting it all together for the pelvic exam. And I encourage you, if you're just starting out doing pelvic exams, to print this slide off and just have it. Just kind of reminds you, well, not just how to document, but what are some things you need to be looking at during your pelvic exam. As mentioned earlier in the presentation, the Women's Preventative Services Initiative. The next few slides are their recommendations for well woman care based on the different age groups. This slide has general health screening that's recommended. You can see that the filled-in circles are going to be recommendations based on A or B evidence ratings, and the not filled-in circles are going to be just recommendations for selected groups. The next slide addresses recommended screening for infectious diseases and cancer screening. You'll see recommendations for annual chlamydia and gonorrhea screening is recommended 24 years and younger. Cervical cancer screening is recommended beginning age 21. And breast cancer screening with mammography is between 40 and 50. And age 50 would be when you would start colon cancer screening. And this will vary based on risk factors as well. These are recommendations for preventative services for pregnancy and postpartum. I just wanted to mention, and I wasn't sure if I mentioned this, but you want to make sure you're screening every woman of childbearing age for pregnancy. Number one, if you have to prescribe anything, you need to know if they're pregnant. If they have any chronic medical conditions and they're even thinking of getting pregnant, you would want to make sure those are under control and they're on medications that are approved for pregnancy. And then you want to make sure that you are able to provide them with contraceptive counseling and services, breastfeeding, counseling services and supplies, and STD screening. And I think that is it. These are more resources for you to have. Again, it can be accessed at the link in the slide above. And I thank you for giving me the opportunity to present to y'all.